When a patient presents in acute respiratory distress, the macroscopic symptoms, gasping, tachypnea, cyanosis, all look largely the same. But at the microscopic level, the architecture of the lung is failing in entirely different ways. An alveolar sac rapidly fills with fluid, drowning the patient from the inside, while nearby, a bronchial tube aggressively clamps shut, trapping air. These two mechanisms represent a strict anatomic divide. The fluid consolidation of infectious pneumonia requires a different physiologic intervention than the smooth muscle constriction of an obstructive airway disease. Attempting to triage acute pulmonary failure by how a patient looks is a common error that leads to delayed intubations and misdiagnoses. To correctly manage these patients, clinicians must override their visual assessment and rely strictly on 4 objective frameworks, standardizing the approach to pneumonia, tuberculosis, asthma, and COPD. By forcing patient symptoms through rigid data stratification, we eliminate the subjective variability inherent in acute respiratory failure and identify exactly when mechanical or pharmacologic intervention is required. Community-acquired pneumonia, or CAP, presents an immediate triage problem. You cannot determine a patient's mortality risk or whether they are safe to go home based solely on a physical exam. We quantify that risk using this scoring interface, the CURB-65 algorithm. It assigns exactly 1 point for each of 5 clinical criteria: confusion, uremia with a BUN over 19, a respiratory rate over 30, a systolic blood pressure under 90, and an age of 65 or older. A cumulative score of 0 or 1 dictates that the patient's risk is low enough to mandate outpatient treatment. A score of 2 requires an inpatient ward admission, but a score of 3 or higher forces a mandatory ICU evaluation for severe, impending respiratory collapse. Once the physical disposition is calculated, the score dictates the pharmacology. For the low-risk CAP patient safely sent home, the empiric outpatient treatment requires coverage for atypical organisms, using a macrolide or doxycycline. Consider a standard clinical vignette. An ambulatory patient presents with a fever, a productive cough, and a lobar infiltrate on an X-ray. They have normal vitals and no comorbidities. You must select the precise initial pharmacotherapy. The correct choice is oral azithromycin. As detailed here, an uncomplicated ambulatory patient with CAP requires targeted coverage against common community bacteria, like Streptococcus pneumonia and Mycoplasma, without unnecessarily escalating to broad-spectrum intravenous drugs. The workflow is entirely linear. The objective severity score dictates the physical disposition, and the disposition dictates the specific empiric antibiotic class. When diagnosing hospital-acquired pneumonia, the defining metric is time. By definition, HAP occurs at least 48 hours after a patient is admitted to the hospital. This 48-hour window alters the expected microbiological profile. We can no longer assume standard community bacteria. The hospital environment selects for multi-drug-resistant organisms. Because of this shift, the mandatory empiric protocol for HAP requires aggressive dual coverage, immediately deploying an anti-pseudomonal beta-lactam combined with specific MRSA coverage, like vancomycin. A separate anatomic variable defines aspiration pneumonia. This infection is driven by impaired swallowing mechanics, typically due to altered consciousness from intoxication, seizures, or anesthesia. When gastric contents bypass the vocal cords, gravity and structural physics take over. The right mainstem bronchus is wider and descends at a straighter, more vertical angle, forcing aspirated fluid to pool directly in the right lower lobe. Because this fluid carries flora from the oral cavity and upper GI tract, aspiration pneumonia carries an absolute requirement for oral anaerobic coverage, typically utilizing agents like ampicillin sulbactam or clindamycin. Time and gravity act as undeniable physical variables. They override our baseline bacterial assumptions and force an immediate shift in empiric therapy. Active pulmonary tuberculosis presents with a rigid, chronic symptom profile: weight loss, intense night sweats, hemoptysis, and cavitary lesions isolated in the oxygen-rich upper lobes of the lungs. When these symptoms align, there is an absolute diagnostic rule. You never proceed directly to an invasive lung biopsy to confirm the pathogen. The mandatory non-invasive sequence requires placing the patient in airborne isolation and securing 3 distinct sets of sputum samples for acid-fast bacilli smears, immediately followed by confirmatory mycobacterial cultures. For asymptomatic, latent TB, the diagnostic timeline shifts to screening. The Purified Protein Derivative, or PPD skin test, assesses immune memory by measuring the exact millimeter in duration of a delayed hypersensitivity reaction. As outlined here in the testing parameters, a patient with no known medical comorbidities and no high-risk exposures requires an induration exceeding 15 millimeters to be considered positive. A result below that threshold is negative, successfully clearing them for standard activities like volunteer work. If active TB is confirmed, the pharmacology follows an uncompromising two-stage protocol. This diagram charts the initial intensive phase, deploying the four-drug RIPE regimen: rifampin, isoniazid, pyrazinamide, and ethonitol. This intense blockade lasts for exactly 2 months. Once complete, the regimen dictates a strict de-escalation, dropping pyrazinamide and ethambutol. The timeline then transitions to the continuation phase, maintaining only rifampin and isoniazid for 4 additional months to eradicate the remaining dormant bacilli. There is one non-negotiable co-therapy rule nested in the sequence. Isoniazid depletes vitamin B6, so it must always be administered with simultaneous pyridoxine supplementation to prevent peripheral neuropathy. From the sputum smears to the precise month-by-month drug de-escalation, TB management is an unforgiving sequence. Any deviation from the established timeline results in clinical failure and pathogen resistance. Baseline asthma maintenance focuses on preventing airway inflammation entirely, prioritizing low-dose inhaled corticosteroids combined with a long-acting beta agonist like formoterol. During an acute exacerbation, that maintenance fails. The protocol instantly shifts to halting the inflammatory cascade with short-acting beta agonists, ipratropium, and systemic steroids. If the patient fails to improve, you must draw an arterial blood gas. This reveals a critical diagnostic nuance in pulmonary medicine: the interpretation of PaCO2 in a severely distressed asthmatic. Look at this tracker. The standard physiologic response to acute airway obstruction is hyperventilation. The patient breathes rapidly, blowing off excess carbon dioxide. Initially, this drives the PaCO2 down below the normal baseline of 40 millimeters of mercury, but sustained tachypnea exerts a massive physical toll. Over hours of fighting against constricted airways, the diaphragm and accessory respiratory muscles reach physical exhaustion. They lose the ability to maintain the rapid breathing rate. If a subsequent ABG shows the PaCO2 climbing back to a normal 40, the physiological state has reached a tipping point. A normalizing CO2 in an acute asthma attack is not a sign of recovery. It indicates that the respiratory muscles are failing and the patient can no longer clear the gas. Recognizing seemingly normal vital signs in a highly abnormal physiological state requires precise data synthesis. That normalizing CO2 is an absolute mandate for immediate mechanical intubation. Chronic obstructive pulmonary disease requires constant bronchodilation to maintain baseline function, heavily relying on long-acting muscarinic and long-acting beta agonists. When COPD exacerbates, deploying empiric antibiotics is strictly dictated by the clinical presentation. You treat only if the patient demonstrates increased dyspnea, increased sputum volume, or increased sputum purulence. However, in severe exacerbations, pharmacological treatments reach their limit. You must evaluate the patient's ventilatory thresholds to determine if physical breathing support is required. This gauge outlines the exact ABG numerical thresholds for intervention. If the patient develops a mild to moderate respiratory acidosis, specifically a pH below 7.35 or a PaCO2 above 45, medications are no longer sufficient. This data point demands non-invasive positive pressure ventilation, commonly known as BiPAP. This is distinct from the separate mortality-driven thresholds for prescribing long-term home oxygen therapy. Oxygen is only added to baseline care if the resting PaO2 drops to 55 or below, or if the oxygen saturation sits at 88% or lower. We see similar rigid diagnostic markers in bronchiectasis, a distinct obstructive pathology characterized by chronic, copious amounts of purulent sputum. The architectural hallmark of bronchiectasis is the permanent dilation of the bronchial airways due to chronic inflammation. On a high-resolution CT scan, these dilated, thick-walled airways present as parallel lines, forming the classic tram track sign. Managing chronic obstructive diseases requires absolute respect for these numerical boundaries and structural markers. Ignoring the thresholds risks total mechanical or hypoxic collapse. Mastery of complex pulmonary pathologies requires entirely divorcing clinical emotion from the objective data. You cannot reliably assess respiratory failure through visual inspection alone. This diagram synthesizes the 4 pillars of acute triage. We rely strictly on CURB-65 scores to define disposition. We respect the diagnostic and pharmacologic timelines of TB. We recognize that a rising PaCO2 in asthma is a sign of physiologic breakdown, and we treat COPD exacerbations strictly against established ABG thresholds. In high-stakes pulmonary scenarios, the raw data dictates the algorithm. Your intuition is secondary to the physiological mechanics. To survive the wards and conquer the boards, you must evaluate the variables, validate the parameters, and execute the protocol without hesitation.